Hey guys, it's Gianna, MidwiFay. Today, for my first installment in my labor induction series, I wanted to talk about help. My doctor says my baby is big. Okay, what do we do in the cases of a suspected big baby? As always, I want to encourage you, please like this video, subscribe to the channel. It really helps me know which videos you guys like and what other content you want. So please go ahead and like and subscribe if you haven't already. Firstly, we're going to get down some definitions, okay? And I'll have a chart here so that you guys can see it visually for all you visual learners like me. So the two definitions we're going to talk about a lot throughout this are a large for gestational age, LGA fetus, and a macrosomic fetus. When we're talking about a large for gestational age fetus, that means that on ultrasound, the baby is measuring larger than 90% of other babies at the same or similar gestation to this baby. So this is an estimate done while baby is still in utero, inside of mom's body. Macrosomia, on the other hand, is diagnosed after the baby is born only. So usually that starts at 4,000 grams, and the data shows that truly the more risks incur after a baby is about 4,500 grams. Here it is in pounds and ounces for you as well. Although America is one of the only countries really that uses pounds and ounces, grams is more universal. So that is why these definitions are shown in grams here. Another important distinction to make here that I'll talk about throughout the video is babies born to diabetic versus non-diabetic mothers. There is a difference in the weight cutoffs here when we're recommending induction or cesarean birth because babies born to moms with diabetes generally have more fat, and that distribution of fat is more in their torso, more in their abdomen and their shoulders and upper limb area. So I'll talk about that a little bit more as we move on. So let's start with statistics, right? How often is someone truly having a big baby by definition? These definitions, I gotta look at my notes, are from the National Center for Health Statistics, okay? So when looking at macrosomia, this is the only way to diagnose it after a baby is born. What percentage of babies are actually macrosomic infants, okay? So looking at a 4,000 gram baby or greater, that is 7.8% of babies are actually in that weight range, okay? Looking at greater than 4,500 grams, much smaller, about 1% of babies. And then even smallest, that 5,000 gram, that 11-pound baby, that's about 0.1%. As I alluded to before, these numbers do change and the risk is increased with a mother with diabetes and or a mother with pre-existing obesity. So I'm going to have this chart here that kind of goes through those statistics on the differences in percentage of having a larger baby based on a diabetic or non-diabetic mother and with the compounded factor of obesity or a normal BMI. So let's talk about having risk factors. What are the risk factors for having a large baby? I've already talked about it a few times. Diabetes, either pre-existing diabetes or gestational diabetes, is one of the most significant risk factors for having a large baby. And specifically, how well are your blood sugars controlled with your diabetes? Having well-controlled diabetes, not requiring medication, etc., usually another important risk factor we see is obesity. So maternal obesity prior to pregnancy, during pregnancy. Maternal obesity refers to a pre-pregnancy BMI, body mass index, of 30 or greater. Here's a chart of different BMIs and weight gain recommendations in pregnancy. So we know that maternal obesity, again, pre-pregnancy BMI of 30 or greater, increases your chance of having a large baby. Some other risk factors include a late term or post-term pregnancy. This kind of makes logical sense. The longer you're pregnant, the longer the baby has time to grow. So of course there's a slightly increased risk with that. Excessive weight gain in pregnancy and fundal heights in pregnancy. Kind of a crude measurement, but when we're measuring your uterus to make sure it's growing appropriately throughout the pregnancy, measuring your weight gain, kind of need to see where you are average or above average with that. These are kind of crude measurements, but can be associated with a larger baby. Another big predictor of a bigger baby is having a big baby before. So have you previously delivered a macrosomic baby, so a baby in that 4,000, 4,500, or much rarer 5,000 gram range? If so, you're more likely to have a baby that big again. So let's talk about how do we know how big a baby is when it's still inside a person's body. The two most common ways we know are physical exam. We do something called Leopold's maneuvers and fundal heights when we're measuring how much your uterus is growing and feeling with our hands how big we estimate the baby to be. Okay, that is done at every OB visit. And then there are measurements that we take with that. If we are above or below a certain centimeter range too many times, then we start to suspect, this baby might be big, or on the other hand, it might be small. So there are trained physical exam techniques that we use. More commonly, what I hear a lot about and decisions are made more based on ultrasound, okay? So ultrasounds are done abdominally, and they are taking measurements of baby. Usually they're taking a head circumference measure, an abdominal circumference measure, and a femur length measure, or some mix therein. And based on those, there are calculations that we do to say how big baby is, give an estimate in grams, as well as give an estimate of that percentile, how big this baby is compared to other babies at this gestational age. That's what that percentile is. So, as all things, like I said, inductions aren't necessarily recommended unless we are expecting risk to mom or to baby. So with this, in this case, what are the risks to mom or baby if the baby is big? Who cares? Specifically, let's talk up with mom first. Risk to mom, the most notable risks are increased risk of C-section and increased chance of more severe tears. The increased risk of C-section part is tricky because this is a perceived risk versus a real risk. There's data that shows that just having this third trimester growth ultrasound and now your provider is suspecting that your baby is big means that he or she will kind of be more cautious with your labor progress, be sooner to say, this labor is taking too long, it's because this baby is big, I recommend a C-section, okay? Or in general, if you truly do have a bigger baby in there, it might cause your labor process to stall at certain points, to protract, which is the official definition, and lead to a cesarean birth. So it's hard to know if it's because we think the baby is big and we're treating your labor differently versus if truly your labor is protracted because of the baby's size. So I think there's a lot of studies being done, and there's a lot that have been done that show an increased risk of C-section for a mom for a suspected big baby. The other big risk to mom is increased chance of more severe tears. Perineal tears can happen with all sizes of baby, but the larger the baby is, the increased chance of having those third or those fourth degree tears with labor. Some other increased risks to moms include increased risk of postpartum hemorrhage and increased risk of chorioamnionitis, which is the infection of the membranes in the uterus during labor. So those are some other things to think about. Now let's get to risks to baby. The most notable risk to a baby that is larger passing through the pelvis is a complication called shoulder dystocia. Likely, if you have been counseled about a labor induction because your baby is big, this is what your provider is talking to you about and warning you could happen. What is a shoulder dystocia? A shoulder dystocia is what happens when the baby's shoulder is coming down after the baby's head is born and the baby does something called restituting, turning to come out. The baby's shoulder gets stuck under the pubic bone, okay? This is a bone-to-bone stuck. It's hard to get the baby out in that scenario. How often does this happen? Shoulder dystocia happens, the incidence is about 3% of all vaginal births, and that increases to about 14% when we're talking about babies in that 4,500 gram range or bigger. Again, that risk slightly increases even more for babies born to diabetic mothers because their fat distribution is in that upper torso, abdomen, and shoulder arm area. So if your baby experiences a shoulder dystocia, that complication during birth, what can happen? It can lead to oxygen deprivation. That can lead to very, very rarely, but it can lead to brain damage for baby. More commonly, there's something called brachial plexus injury, which is one of the nerves here in baby's neck. So with the strain of trying to get the baby out on whichever side it is, we can have brachial plexus injury, which requires physical therapy for baby. There can be damage to the baby's arm or collarbone. So either it could break in an effort to get the baby out. Either we have to break it ourselves, again, very rare, or it just happens as baby's coming out. So these complications that I'm saying, I don't say them to scare you. I say them because they are things that can happen, but very, very rarely. Again, shoulder dystocia itself happens in about 3% of all vaginal deliveries. These severe complications is much smaller amount than that. I actually will look up some data and have it in the comments so you can take a look. I have to add in here that although having a large baby, that 4,500 grams or greater, definitely increases the chance of having a shoulder dystocia, most babies that have a shoulder dystocia at their birth are normal weight, okay? And a shoulder dystocia is a very unpredictable labor complication. So I say that to say, anytime that I feel, there's been times when I've been prepared for shoulder dystocia, the baby's measuring big, I'm really ready for it, and it doesn't happen. And vice versa. I'm having a total normal labor progress of a baby that I suspect to be a normal size, and I have a shoulder dystocia, and the baby is a normal size. So having a large baby is not the only predictor of a shoulder dystocia. It is an unpredictable complication of pregnancy that occurs. Another risk to baby, if baby is born big, is hypoglycemia. That's low blood sugar. This especially happens in cases of diabetes, because this is what happens when a baby is in utero and exposed to the increased levels of sugar that mom has. Then the baby starts to make lots of insulin to compensate for that. Now baby's out and not in that environment of a lot of sugar, but still making a lot of insulin, which is causing baby to have lower blood sugar. Lower blood sugar for neonates can lead to a variety of complications, and so that's why we monitor baby's blood sugars if baby is born larger or born to a gestational diabetic mother, so that potentially baby might need some more support in the NICU or the nursery. So now that we've gone through all that, the definitions, the incidents, the complications that can happen, what do I recommend? Firstly, I recommend preventing as much as we can. So let's go to the biggest risk factors: obesity and diabetes, specifically uncontrolled diabetes. The more you can work to prevent that, the better. Exercise, exercise, exercise. There's lots of research on exercise in pregnancy and its benefits for increasing chances of a vaginal birth, decreasing C-section chances, controlling weight gain in pregnancy. Now looking at fetal size, newborn size to moms who exercise. So exercise and eating well, those are huge preventative tips. So I definitely recommend that on your end with prevention. I also say, again, shoulder dystocia is a complication that can happen with any birth, let alone with a baby who is big. Please know that as OB teams in and out of hospital setting, shoulder dystocia is one of those complications that we routinely practice in simulation so that we work well as a team to resolve that. My other recommendation, almost equally as big, is please don't have unnecessary ultrasounds. If you are a normal, low-risk pregnant person, a third trimester ultrasound for weight, this 36-week growth ultrasound that we're seeing more and more, is not indicated, is not necessary. I know it's tempting. I know you want to see your baby. It's so exciting. It feels like a long time since that anatomy scan at 20 weeks when we saw the baby. However, we know when we go looking for unnecessary problems, we might see something, and the data just shows that that something that we see is not accurate a lot of the times. I'm going to have the quote here from ACOG. It's from their Safe Prevention of Primary Cesarean, and it cautions against the use of routine ultrasounds for growth in a normal, low-risk pregnant person because of the implications that can happen and the cascade of interventions that can happen based on ultrasound. So again, as you read the statement, it basically urges us as providers to counsel patients on the potential inaccuracy and not make major clinical decisions based on ultrasound alone. As always, I'm going to recommend that you use your brain, go through that acronym with your provider. What are the benefits, risks, alternatives? Listen to your intuition. What if I do nothing? Important to go through these questions with your provider so that you can feel informed in regards to making a decision to be induced or not based on your baby measuring big. My other recommendation is to educate yourself. Educate. The more you know about a normal labor process, normal labor progress, the better equipped you and your partner and support people are. So if someone is coming to you saying this is taking too long, this is not normal, if you have done a really comprehensive childbirth education course to know how long a labor process can be, especially for a first-time mom or not, or an induction versus spontaneous labor, if you know these things, then you're able to kind of push back when someone might be saying, this is taking longer, I think it's because the baby is big, I recommend a C-section, etc. The more you know, the better. All right, guys, I hope that helps. I'm going to have some other really useful information in the comments, specifically the evidence-based birth, article on induction for big baby, Dr. Nicole Rankins, who's an amazing source of knowledge. She's an OB who has an online childbirth preparation course, and she did an amazing podcast episode on this that really covered it. I'm going to link that below too. So again, I hope this helps. Please share it with someone. Let me know if you have any questions in the comments. I'll see you next time. Bye-bye.